Hello, everyone. This is Michael Ostacher at Stanford University. I'm the digital content editor for evidence-based mental health. Thank you for joining us today. Thank you for your patience if you're waiting to join us live. We have a terrific discussion today of a terrific paper that's published in our journal, Preventing and Treating Mental Health, Preventing and Treating Childhood Behavioral Disorders, led by Charlotte Waddell, who's at Simon Fraser University in Vancouver, Canada. We have a number of discussants with us today. I'd like to introduce Professor Waddell's team. She's the university professor and director of the Children's Health Policy Center at the Faculty of Health Sciences at Simon Fraser. She has a team at the Health Policy Center in Vancouver that, among other projects in consultation with policymakers, prepares systematic reviews of research evidence on prevention and treatment of interventions to inform children's health programs and services. She also actively communicates their findings through meetings and talks with policymakers, frontline practitioners, and community groups, providing clinical interpretations when needed. We're joined by her colleague, Jen Barican, who's the research manager for Children's Mental Health Research Quarterly, the electronic publication that they publish, and Christine Schwartz, who's adjunct professor in the Children's Health Policy Center too. She's the lead scientific writer for Children's Mental Health Research Quarterly. We also are delighted to be joined by Bev Gutray, who's the CEO of the Canadian Mental Health Association, BC division. She's led the BC Association as part of Canada's oldest mental health charity for over 20 years. We're also joined by Rob Lampard, who's a registered psychologist with practice and policy experience in child and adolescent mental health services. He's the executive director of Child and Mental Health Policy for the Ministry of Children and Family Development in British Columbia. He was a tertiary child and adolescent mental health program in Victoria from 1990 to 2008 and worked in homeschool and community settings prior to moving into his current work in strategic and operational policy for the British Columbia government. We also are joined by our editor-in-chief, Andrea Cipriani, who joins us from Oxford, and I'd like to give thanks to people behind the scenes, including Veronica and me, for getting this hangout off the ground. Charlotte, why don't you get us started? You can share your screen with the paper that we're going to be discussing today, and maybe you can walk us through it, and we can begin I hope an interesting and free-flowing discussion about it.
Thank you so much. And can everyone see the slides?
Yes.
Yes, Charlotte.
Okay, so if I simply, I can simply walk through the slides now, I take it.
Yes, go ahead.
Great. So Christine and Jen are on the line with me, and Caitlin and Donna, our other two authors, are not able to be with us today, but indeed we have recently published with Evidence-Based Mental Health a systematic review covering 50 years of research. The second slide shows really just that we wanted to look at both oppositional, defiant, and conduct disorder. These problems have a high community prevalence, between 2 and 4%, but maybe more importantly, both start extremely early in the preschool years and cause tremendous costs for individual children and families, but for society as well, with the added costs, for example, healthcare, justice, child welfare costs added on. We also were interested in these problems because we're persuaded by the literature that there are causal links between some particular forms of social disadvantage and child maltreatment leading to greater prevalence of child behavior problems. And we think that just, having that causal link really noted is important for ensuring that we attend first and foremost to children's rights. And one of the rights is, in our view, to have effective prevention and treatment programs available for all kids, either at risk or who have symptoms. For our systematic review methods, we wanted to also look at, so now on the next slide, a range of childhood interventions, the full range actually, from early prevention programs through to psychosocial treatments, but also pharmacological treatments, because we know these are being used, certainly in Canada, but we understand in the US and the UK as well. So we looked to ensure high quality evaluations, randomized controlled trials published from 1965 onwards. We looked for robust outcome measures, reasonable attrition rates, reasonable follow-up, and things like double blinding and placebo controls. And the team looked at over 1,800 records, and we found 37 RCTs, if you will, described in 165 articles that met our criteria. So the prevention programs, what did we find? 16 RCTs evaluating 15 programs, 13 showed benefits. Follow-up was very interesting. It ranged from as little as 3 months to up to 35 years in one case. And we found programs that reduced either diagnoses, in other words, incidents, or reduced very serious symptoms, such as those that might lead to criminal behavior. So good behavior game, classroom-centered intervention, fast track, coping power, nurse-family partnership, parent management training, Oregon, and Preschool were all in that top list. And then others reduced at least one symptom, Chicago Parent, Family Checkup, Family School Partnership, Incredible Years, Ready, and Triple P. What about the psychosocial treatments? So once children have enough symptoms to merit interventions on that scale, we found 8 psychosocial treatments, 5 of them depicting benefits. Follow-up much shorter than for the prevention programs, but some did go up to 8 years. Those treatments that reduced diagnoses or those very serious symptoms included Incredible Years, brief intervention, multidimensional treatment foster care, and multisystemic therapy. And then one other program at least reduced one symptom, and that was parent-child interaction therapy. And finally, what about the pharmacological treatments? 8 trials, 5 medications, all but one really showed some child benefits. None showed any follow-up, however, after RCTs ended. All at least, those that reduced at least one symptom, haloperidol, lithium, quetiapine, and risperidone, showed up well, reasonable, significant reductions in symptoms in the trials. But in every single case, there were adverse events in the majority, more than half of the children. And by adverse events, we were quite concerned to see sedation, weight gain, things like nausea and vomiting, excessive thirst, urinary frequency, psychiatric symptoms such as irritability, agitation, anxiety, and even fatigue. So what do we conclude and what do we suggest are the implications? But we very much look forward to the discussion, including your reactions, Rob and Bev, as people who are very immersed in thinking about these kinds of programs and how do we apply these findings. We felt that we found strong evidence for prevention programs overall, based on the number of RCTs and based on positive benefits over many years of follow-up. And we thought there was moderate evidence for psychosocial treatments based on some solid RCTs, but it sure would be nice to see more. The medication evidence concerned us, however. Yes, there were some benefits. On the other hand, all of the medications caused important adverse events. So we felt overall that prevention programs, the effective ones that is, should be made available to all kids at risk of oppositional, defiant, or conduct disorder. Effective psychosocial treatment should also be made available to all kids with symptoms, but medication should be a last resort. And certainly what we're seeing in British Columbia and other parts of Canada, the reverse is happening in the sense that prevention programs are not widely available as yet. And kids may or may not be offered psychosocial treatments. Rather, particularly when children are sent to physicians, medications are prescribed sometimes as the first choice when they should be the last choice. And really, to enact this, we felt that, and we still feel very strongly, children's mental health needs a comprehensive public health approach that clearly includes prevention alongside psychosocial treatment, and then drug treatments only as a last resort. The last slide just shows what might be one of the kids that could benefit from these interventions, and we just wish to thank our funders and those that have supported our work. I'm now going to exit the slides, and
That's great.
Thank you.
Perfect. Yeah, thank you for doing that. So how would you like to have the discussion unfold, Charlotte?
I would like to first just check in with Christine and Jen and see what you would add, and if there are any other overarching comments you'd like to make before we maybe turn to Rob and Bev.
I'm great with turning it over to Rob and Bev now.
Jen, what about you?
Yeah, I think you've covered it all. Really, this paper is really written to encourage the use of research evidence really in policymaking, to invest in programs that are beneficial to kids, particularly prevention programs, and to also really to encourage also the use of research evidence in practice to make sure it aligns with what works and what is effective, and also to encourage researchers to really conduct more high quality studies and to adhere to reporting guidelines such as CONCERT, because it's just to make sure everything is consistent and to really highlight that they've done methods that reduce biases. So that's all I'm gonna say, because it's really what the goal of the paper. That's pretty much it.
Thank you, Jen. So Rob, you're the leader for children's mental health community-based programs in our province, and we've worked with you for quite some time as well to really try to make our work as researchers relevant and useful to you as a policymaker. So very interested in your reactions.
Yeah, thank you, Charlotte, and good morning all, or whatever time of day it is, wherever you're watching. As Charlotte was saying that there's been a relationship between the policy branch that I'm part of for the province of British Columbia and the Children's Health Policy Center that predated my joining the team back in 2009, goes way back to early 2000s. And so the excellent work that you've heard about today is just part of a large sort of fabric that's been woven over many years that involves wonderful policy practice partnership with this research team. It influenced public policy in a huge way back with the development of the Child and Youth Mental Health Plan for our province that was implemented between 2003 and 2008. It was a 5-year plan. And Charlotte and her work subsequently had a huge influence in the development of the province's then lifespan mental health strategy. It was a 10-year plan that was in place until recently, and I'm part of cross-government work now that's developing a new strategy. And so at each of those occasions, Charlotte and her team's work, and Charlotte and her team personally have had huge input and influence on the public policy landscape. Back with the 2003 to 5 plan, reviews such as the one that she's just presented here on today on behalf of the team had a lot of influence in terms of where our public investments were made and what our publicly funded training. We have 90 child and youth mental health centers throughout the province. We provide training and evidence-based interventions, and so the type of evidence information that Charlotte's provided has helped helped us with on the practice side and on the intervention side with investing in some things rather than others. So that's been a huge benefit. It's also influenced the strategic planning, as I refer to. So those things have been valuable, long-standing partnerships that the province as a whole and the kids in the province and their families have really benefited from. It would not be accurate for me not to say that there's always been and probably always are in every jurisdiction, challenges with getting the full uptake and the full buy-in. It remains a challenge to have the consistency. We have things like Triple P and parent-child interaction therapy, a number of other evidence-based interventions or prevention programs available through our ministry. The ministry that I work with has responsibility for child and youth mental health, as well as for our child protection, child welfare programs. And so we invest, the ministry does, in the clinical services, but also in prevention programs. But our ability on the policy side to influence consistency and having these available equally throughout the province, there's a lot of local need for local, I guess, input and control over resources. There's still challenges with supporting the uptake of evidence-based interventions as your first line versus other interventions. I think we're doing well, but I think I'd be remiss to not acknowledge that that's an ongoing challenge. The partnerships help. The partnership that we've had, we meet regularly with Charlotte and Christine and others from the team, has really helped influence that. We also, Charlotte, as she has done here today, meets with our over 90 team leaders on a quarterly basis to present reviews such as the one she's done today on the Children's Health Policy Center does a quarterly publication that our ministry in part supports through funding. And so those evidence reviews are made available on presentations such as this. So all of that has been huge and has a long-lasting and positive impact on work that we do. It also has helped influence investments such as in the work that Bev Gutray through the Mental Health Association, the BC chapter, has done, and so that it's influenced our investment in parent management training Oregon, which the BC version of that, I'll let Bev speak to that, the Confident Parents, Thriving Kids. So you can see sort of there's the policy practice kind of connection there. So I'll stop. I've said quite a bit already. I'll stop at that point. Maybe open it for, I don't know, Charlotte, I'll let you kind of steer us where we need to go to next, but I'll open the floor.
Great. Thank you, Rob. And Bev, we'd love to hear from you.
Sure. It's a great privilege to be part of this team. I've really enjoyed our work with Charlotte and with the Ministry of Children and Family Development. So we were able to launch a province-wide program, a telephone-based delivery for supporting parents called Confident Parents, Thriving Kids. And it's based on telephone coaching. So that's the adaptation that's different than how the parent management training program in Oregon is actually delivered. It's actually delivered face-to-face. So our adaptation is the fact that we're able not only to access good evidence-based programs, but also to help parents across the province have the reach. Because as we know, we have a large geographic area, we have rural, we have remote communities, and that is a significant challenge in BC, is actually getting the right service to the right people at the right time. The other part of the program is we are parent friendly in the way that if parents or guardians actually want to participate in the program, we have Saturday hours, we have evening hours, etc. So really making it make sense. And by far, that is the most desirable time slots. About a year ago, we had a wait list of over 500 parents on an early intervention program, which is quite contradictory to what we're trying to do. But because we were able to open up more evenings and more Saturdays, that wait list now at the beginning of this year, we actually don't have a wait list at all. So any guardian, any parent from across BC can access the program. What we liked about the program was not only that we were able to adapt it to telephone delivery, but there is a full community transfer ability. So as we have our own trained coaches and our trainers and reflective coaches and fidelity raters, we can now start looking at what is known as Generation 2, which would allow us to train people across the province who are in child serving agencies to actually deliver the program face to face. So the policy win is being able to have the same kind of service delivered face to face as you do over the telephone. And that's what we're looking forward to. That's what we're working towards. We have not done any promotion of this program, and it's to this point, it's been a direct support to pediatricians, physicians, and psychiatrists. So it's on referral from them. And we were busy from day one. We're now looking at other referral pathways, such as through the Ministry of Children and Family Development, and actually looking at wait lists that are attached to those services. The beauty of the relationship is the partnership. The beauty is having Charlotte and her team help us to stay grounded in the evidence and to review the program that we're doing. We couldn't have done this without Charlotte's team, and certainly the ministry has been alongside us every step of the way. I think that's about it, Charlotte.
Thank you, Bev. So maybe could I turn it back over to the people from the Evidence-Based Mental Health Journal, and just, what we've presented is maybe a pretty positive picture. Are there perhaps controversies, or are there downsides to the way we're describing doing this kind of systematic review work and having it feed directly into policy and programmatic activities in the community? Is this really maybe something that works well in our province within Canada, but might not have, or might have, wider applications elsewhere? So I'd love to just open it up more widely.
Yeah, I can ask a question, Charlotte. It's about the paper, just to go back to the evidence. And one of the things that is striking to me is that the most robust evidence is about the prevention programs, as you pointed out. And I think it's interesting to underline that you have 16 trials evaluating 15 prevention programs. So one of the first questions is the replicability of these findings. You have basically one trial per program. And I was wondering how different they are, if there's those sort of overlap of these kind of programs, and how much is about promoting my own program rather than trying to find something which is replicable and usable elsewhere.
I really find that question helpful, and I'll make a brief start on responding and then look to Christine and Jen to join me. I would say, and it's maybe going a bit beyond this one review, because we regularly cull through thousands of papers trying to answer that kind of question exactly regarding all of the childhood disorders and a really wide array of prevention and treatment programs. But the point you're making really does apply very well to prevention. So I would say some of the programs, and it may not be as reflected in our review as it could be when you look at the wider literature. For example, programs such as Incredible Years, there have been, Jen, you can verify this, but I think there have been 10 or 15 trials now. We didn't include them all because we had quite precise inclusion criteria, as you know, in the article that we published with you, just really to zero in on what we felt were policy and practice relevant questions. But there are a number of trials, and there have been a number of replications, for example, for incredible years. The same is true for a number of the other programs on our list. Parent Management Training Oregon, for example. Bev, you're doing a replication in British Columbia with a really innovative kind of community-based evaluation. Nurse-family partnership, people are perhaps aware, 3 US randomized controlled trials, some with 20-year follow-up, and then trials in the Netherlands and in England. So replications there, and we're currently conducting a replication RCT in British Columbia of NFP. So, there are a number of times when things have been replicated. There are still, however, a number that haven't, and where they remain in a way unique. So Fast Track comes to mind, for example, very, interesting results. Long-term, impressive long-term follow-up, for example, reducing things like antisocial personality disorder in adulthood, but very tough to replicate that program just because of, it taking a number of years, it being a huge policy investment. So not one that's going to be as easy to take up. I think one of the other aspects of your question is just the thing that we get asked a lot about, and you must at the journal as well. When something is conducted under research conditions, are those idealized conditions, or can we be conducting more trials in so-called real-world conditions? And what will the results be in that case? And I think the research community needs to definitely pay a lot more attention to that. So, Bev, the work you're doing on Parent Management Training, Oregon, that's a real-world kind of evaluation. And we've specifically designed, for example, our nurse-family partnership trial in British Columbia to be embedded within our working public health system. It's a very interesting experience. Will we get the same kinds of results as those more, the kinds of RCTs that were done in the US, for example, where it wasn't particularly embedded? But Christine and Jen, what would you add?
One piece that I would say is that one of the ways that we were trying to make sure that we weren't just getting research that someone had a vested interest in to promote was our rigorous standards. So we were looking for behavioral indicators where there was one diagnostic measure where the diagnostician was blinded, or conversely 2 symptom measures by 2 or more informant sources, so a child or a parent, and at least one of whom was blinded to condition. So that's one of the ways we were able to ensure that if somebody indeed was wanting to promote their program, their evidence still met our rigorous standards. And I'll turn it over to Jen.
No, I think you've covered it, Christine. I think it's just a rigorous inclusion criteria. And some studies also, they do some replication studies, but would compare it to not necessarily a control or a TAU, but a treatment as usual, I should say, but instead it would compare it to another program. So when that happens, those studies don't normally wouldn't meet our criteria, just because it's not the intervention is not compared to a control. So just because of our rigorous criteria, that some of the replication studies weren't included in our review.
But just to maybe wrap up and bring it back to your question, ongoing in our, I would say, our regular work producing short form, pragmatic, systematic reviews on a regular basis. So apart from what we just had published with Evidence-Based Mental Health Journal, it's a principle that we've tried to adhere to, and we really want the research community to think about. If we're going to recommend that a policymaker like you, Rob, or someone like you, Bev, running large-scale provincial programs, we do think indeed that there should be at least one replication showing success in a pertinent population, and that the replication work itself is incredibly important, and just in general, not just for prevention programs, but also for some of the psychosocial treatments. And there, I think we are often lacking, and it's something that I think your journal encourages, and I would like to see more researchers engage in. Just very helpful to give an opinion to policymakers, for example, that's based not just on one successful trial.
Sure, and I think also to highlight the difference between these kind of prevention programs and the pharmacological evidence. I think you're absolutely right, because when you rate the pharmacological studies as sort of last option, also because we know we have a huge problem with these trials, which is the publication bias. So the 8 trials might be a selection of all available evidence, and this is a sort of neglected area from companies. I think it's a very difficult task to summarize all the evidence about this issue. But going back to your comment about impact, this is exactly what I wanted to ask to Rob, because from the outside, from the old Europe, it's amazing to see how researchers, public advocates, government, you're all working together. It's this fantastic collaboration. Mm-hmm. And one is how replicable it is in a place where we only are able to do Brexit. And the other side is how do you monitor the impact on this? Because you are suggesting a pathway, and it would be interesting to collect data about the outcome of this endeavor.
Well, thank you for the question. I think it's a really good question, because it does start to get under the hood of sort of the complexity of what we've been dealing with, what anyone who would embark on this probably has to deal with. I provided my initial comments were kind of a higher level description, but when the rubber hits the road and you're getting into some of the complexities that you described, that you're starting to confront some of what I think are the policy practice research kind of challenges that I think remain challenging, and probably I'll back up a little bit then and just speak to one of the key things for us has been, I think, the long-standing investment in the partnership with the Children's Health Policy Center. This I think is does require a commitment and convincing policymakers to make that and the governments attached to them, to make that investment in the kind of partnership that we've had with Children's Health Policy Center for some time. And I know that Charlotte and her team do other work through other funding sources, but being part of and having public investment in the partnership, I think, is a huge part of being able to support this in a long-term, sustainable way. And so I think that's a key part from my perspective, is that partnership needs to be funded, and there needs to be sort of public commitment to doing that in a sustainable long-term way, because the policy practice issues are ones that need a long-term attention, focus, and continued work.
Rob, how do you on the government level decide whether to put resources in based on the evidence that the group at Simon Fraser has worked on? So how do you make that sort of rubber hits the road decision?
Very good question. So I would say there are two main ways that this can kind of impact, two primary kind of streams. One would be when we're doing, when government's doing strategic planning that's kind of longer term. And there will be public investments that would be in place for the longer term, often attached to a mental health strategy, and probably similar in other jurisdictions. So the partnership that we had with Children's Health Policy Center way back when we implemented the Child and Youth Mental Health Plan did influence investments in a number of things. At that time, one of the key ones that I could point to on the prevention side was around the FRIENDS program, anxiety prevention program. We, as a province, invested in doing that, running that as a provincial program, prevention program. More recently, through the 10-year plan, Charlotte has described as family partnership. Government has invested in that program attached to, again, the mental health strategy. More recently, through the strategy, it was a bit short-lived because of a change in government, but we had increased funding for the what had been piloted through previous mental health strategy. That's the one that Bev's attached to, the TMTO, the version for BC. So through those larger or longer-term strategies, there are often investment strategies attached to them, and so that's a huge source of influence in a big way, and often over multi-years. And then the other would be that in between there are, each of the involved ministries, because usually those strategic plans are cross-government and in our province, it's typically our ministries of health, education, and Ministry of Children and Family Development. So those large ones often will impact all. But the ministries are all working through their respective mandates and with their roles in between on investments. And so there are investment opportunities and practice shift opportunities that come up in between. And so that's where our ongoing relationship with the center can help influence, if we're going to make changes in practice, maybe we're investing in new training for our staff. That's where we can kind of do that on the fly and in the interim through having the good information easily available. Also, we often have Charlotte kind of connect, Charlotte and others, with our more senior leadership, and that helps influence the sort of policy discussions in an important way, and often in between those big strategic planning opportunities. Hope that gets to what you were asking about.
No. I think it does, and I think it's important to have leadership at multiple levels, clearly, who have an ability to communicate well and are able to let people know what might be the best interventions to make. And clearly, Charlotte is an incredible and mature voice for doing this. When you look at the data that you do have, and all of you probably can answer this, how do you know which populations from the data that you have are the ones that are most appropriate to intervene with? So one could see doing sort of, just basing an intervention just on income, or a certain segment of schools that have certain kids in them or parents in them. Or do you make decisions based more on more secondary or even tertiary prevention aspects? And how do you decide which of these data are best in terms of which ones that you end up implementing?
I'd like to highlight an issue, if possible, because it's related to the evidence and the research. And in British Columbia, for example, the parent management training Oregon model that we're implementing, we have a significant Indigenous population. So this program was not developed or co-developed with Indigenous people or Indigenous nations. We were fortunate to have a pilot with one of the bands. But when you think about cultural context and you think about what parenting means, at least in Canada for Indigenous people, and then you say you're going to do a parenting prevention program, for Indigenous people, this is where children were taken away, right? They were sent to residential schools, etc. So cultural context is really important. And I think that's the area that with Rob and Charlotte, hopefully, we're gonna work towards, and learning more and adapting more, because it's a significant missed need in so much of what we do and we call evidence, because there's different kinds of evidence, right?
I mean, yeah, go ahead.
I'd also add to describe, because I think she's really hit on something important and kind of links to your point around how do we focus our efforts, energies, and resources on the populations most in need of perhaps targeted types of prevention or early intervention or intervention work. And certainly for our Indigenous populations, that is a big consideration in all of our work. And Bev and her team have done an awesome job of work on that front. And we've been in dialogue with Bev on the, as she mentioned, they no longer have a wait list for the program. So we're looking at how we might improve access for families experiencing risk who come into contact with our child welfare services. And I think there's some reference in the paper to the universal proportionalism. And so how do we help improve access for those with those kinds of resources? And so those are a couple of examples of, I think, where we've been able to work kind of across the policy practice and research sort of streams to try and improve access. We've got a lot of work still to do on that front. I wouldn't want to make it sound as though we've achieved what we're setting out to do, but I think the dialogue is really helping us, or the input and the information through the Charlotte's team really helps inform us as we go forward in those efforts.
I mean, sitting here in the United States, I think it's remarkable that we have university researchers, mental health association and government people on the same call. I think that's not something that happens very frequently, right? That there's this level of cooperation and trust between groups. I really think it's important to acknowledge that. But to get back to my question, and maybe Charlotte, you would sort of weigh in a little bit about how you weight the evidence. The interventions start when people are in toddlers, and go through to when they're when they're in adolescence, high school, whatever, however, when they're in their teens. How do you decide, where to put your resources based on the evidence? In other words, is there a place where you get the biggest impact for the amount of money or training resources that you have to use to do this? And is there enough evidence from what you've reviewed to even make those decisions?
So I think that, at heart, I hope that's always going to be an empirical question where we may think that we have strong feelings or strong opinions, but we always, I think if we really want to help children and make a real difference, we always want to go back to the evidence. One of the benefits of having this kind of long-term research program with its allegiance to, randomized controlled trial and systematic review methods is that we're always sifting through the evidence, and that puts us in a position to have at our fingertips, new information coupled with the old that can hopefully allow us to, inform people like you, Rob, and you, Bev, or others, just, where are the best places, but just, so I hope that my response is driven empirically by just, the ability that running a systematic review shop gives you to be able to be aware of a large, body of research evidence over time. I would say, and Rob, you know this from numerous conversations we've had, when particularly bringing it back to the behavior disorders in particular, when we think about those causal factors, and that evidence comes from other kinds of research like longitudinal studies, but it does also come from randomized controlled trial or experimental studies. We always want to go way, way back and look at the root causes of things. And regarding behavior disorders in childhood, that starts really, really early. It starts even before children are born. So are there things we can do during pregnancy, for example, to prevent problems, prevent substance exposure, have the family be as prepared as possible to do a great job with parenting and to be able to enjoy that and encourage their child's development. But then, right after the birth and then onwards, many, many things can be done. So the Nurse Family Partnership Program, don't yet know if it's going to work in Canada. And in England, the trial did not show positive effects, but we're hopeful it may in Canada, in British Columbia. But basically, you start work in early pregnancy with the young parent-to-be, taking a targeted approach. And then you carry that on until children reach age 2 years. therein trying to address one of those underlying causal problems, child maltreatment namely, and also, the goal is to have reductions in child behavior problems by age 2 being demonstrable. But from there, thinking of things as a continuum, there's also programs that can pick things up. The Perry Preschool model, one of the terrific American contributions, in my view, just, landmark work and incredible long-term follow-up. But those early preschool years, again, taking a targeted approach, carrying on, and then not letting it drop. There are things you can do in the early school years and in the middle and later teens. So what we've taken, and Rob, this is where working with you and other policymakers has influenced us, trying to take a full spectrum approach from the early prenatal times through until late adolescence. And we've come to a place of advising people like you, Rob, to think about having effective interventions in place across that entire spectrum. Don't wait and start at age 5. Don't even wait until age 2. Certainly don't wait till the teen years. Start in pregnancy and carry on through until the teen years, and have an effective overall public health plan for kids' mental health that covers all of that. And that covers those things always with effective interventions. And we're just talking more about the prevention side of things, but the treatment issues, if you do that kind of comprehensive prevention approach, you should be able to reduce treatment demands, treatment needs going forward. Is that being evaluated? Do we need to evaluate that? It's not being evaluated at present. It is not in British Columbia, certainly, but are there ways that we could evaluate that? I think we should be looking at that here and elsewhere.
So Charlotte, I'd like to add on to what you said, that the importance in choosing programs, looking at things like causal risk factors, and the importance of intervening early to save children, families, and society from experiencing the distress if we wait till the symptoms become more severe. But one other piece I'd want to add what our paper did also look at is for the researchers who calculated effect size to give us a robust measure of how well the intervention worked. And also looking at another data set, we were also able to include cost-effective analyses for some of the programs. What we understand is some of the programs can be quite costly, but if you look only at the price tag, you're only seeing one part of it. I think you have to look downstream and see, well, what costs are we going to prevent, such as criminal justice costs, by intervening early. So I think the data can also help us answer those questions as well.
Right. I mean, I think, I'm just looking at your tables, the more targeted, well, you have universal programs and targeted programs both that seem to prevent antisocial personality disorder, which in and of itself sort of has a dramatic, I think, association with criminal behavior compared to not having that. Although you don't need that to be engaging in criminal behavior, the probability is a lot higher. Is it better to focus on those programs where you have a known outcome that will have a specific benefit rather than one that is only a benefit for, let's say, symptoms that people are hoping to reduce in the future? In other words, how do you make that decision? And then to go on a little bit more with it, the biggest bias problem when you look at risk of bias in your paper for the systematic review that we published with you, performance bias is high in all the interventions. And so how do you account for that, given what you said earlier, which is that you do want to do what the evidence suggests is the right program to intervene with, rather than just doing what you think is a good idea because you're attached to it, right? And so how do you sort out the performance bias issue when making decisions about how to make recommendations to people who actually implement the policy?
So I'll just jump in for a moment, and then Jan, I'll let you speak to some of the performance bias issues and how we tried to approach those. we've generally, our group has landed on feeling that if a program can prevent diagnoses, in other words, reduce incidence, that is, a really, really robust measure. And it might not be antisocial personality disorder. It might be conduct disorder diagnoses in childhood or oppositional defiant disorder diagnoses. That's huge. That is a significant, I think has tremendous clinical significance and should have tremendous policy significance. On the other hand, the majority of studies don't do that. The majority of RCTs, and as we know, all of us, conducting any RCT is a tremendous amount of work, great expense, tough to get funding. Certainly, I can only speak for Canada, but it's been tough to get funding for, large-scale randomized controlled trials of interventions with kids that would take into account things like diagnostic measures. So many more people, certainly when we look at the literature, look at symptom measures, and that is also important because reducing significant symptoms is has clinical and policy importance. But where you can find diagnostic reductions, that's great. The trouble then is marrying that, though, to a program that is realistic to recommend to a policymaker like Rob or to someone like you, Bev, to say this is implementable. So fast track is an example. Once again, we thought the results were very impressive, both symptoms and diagnoses, but very, very, really an impossibly large expense and impossibly large time commitment. So they did it in the US, the research team there. It was fantastic. It has not been replicated to our knowledge. Very, very tough to bring that into the community. One other thing I would just say before I turn it over to you, Jen, the issue of making a recommendation that is something that the community can actually achieve, something that can be realistically implemented and sustained. Really working even more closely with policy and practice partners to really, get the program up and running, get it delivered with reasonable fidelity, and then evaluate as you go. Many times people do pick a program and they may even pick it based on the evidence, but then there's no further evaluation. And I think we miss opportunities when we don't do in situ ongoing evaluations of whatever we do choose to implement. So Bev, your work where you're using, really interesting community-based but robust evaluation approach, I think you're leading the way and showing people how they can do that without having to go to all of the work of an RCT. But I'm going to take it back to you, Jen, just to speak about bias issues and how we try to assess those. And indeed, there are many.
Yes, for our studies, for our review, we recognize that for prevention studies as well as psychosocial intervention, it is quite difficult to find studies that have blinded their participants. Participants would be aware of whether they are participating with their treatment or a control. So it is. We find that it is quite difficult to find studies that would have true blinding in comparison to pharmacological studies where they do implement or conduct double blinding studies, and which is giving basically pills to a control and a treatment, and that are quite similar. So there is that difference. But given that majority of the studies that we've assessed and have accepted in psychosocial and prevention studies, they conducted multiple informants. So that would just corroborate any self-report measures that we've included in our study, in our review. And more of the blinded outcomes were also significant than we found than non-blinded outcomes. So that's how, I think for this kinds of this kind of reviews, it's really just a matter of finding the balance, and whereas a lot of pharmacological studies have conflict of interest, but they did do double blinding. It's just acknowledging that psychosocial interventions and prevention studies it's quite difficult to implement in a randomized control trial where participants would be blinded. So we do acknowledge that those performance in those studies.
That is that the participants that are randomized to receive the intervention may feel better about whatever they're getting than the people who get the control. That's true. We're going to need to wrap up in a minute or so. Charlotte, do you want to sort of wind this down for us, if you could?
Well, just maybe one comment to help wind things down. Doing this kind of systematic review work and trying to find reasonable randomized controlled trial evidence to inform policy, to go into a regular meeting with Rob and say, Rob, here are 6 new programs. It's really important, we think, to avoid what some people in the literature have called systematic review nihilism, where the standards are so high that we would end up saying, Rob, we've got no programs to share with you this week.
Right.
We've got nothing to offer you. That's actually not good enough. And in this way, I may be speaking more to the research community. We need to be doing more pragmatic randomized controlled trials, but we have to give policymakers something to act upon to improve things for kids. So in the end, having systematic review methods, having studies that are done to a high quality, very, very important. But we also have to interpret those and give policymakers something to act upon. And so I would say that's really an important ongoing role for a journal like Evidence-Based Mental Health, where you discuss all these issues and discuss myriad topics. And I think always having, in the end, something that is going to be of utility to help children. That's our bottom line.
I think that's terrific. I think that's a terrific place to stop. I've already mentioned it. I think it's remarkable that we have such an integrated group of people who implement policy, advocates for policy, and researchers together. And your leadership, Charlotte, is clearly outstanding, and the reasons that you're doing it are unquestionable, obviously, by helping kids. And I think the point about not having systematic review nihilism is important to state, because people's lives are really impacted by not having an intervention and not acting. So I think this is remarkable. I wanted to thank you all for taking the time to join us and your patience in getting this off the ground. The technical things are often quite difficult, but I really wanted to thank Charlotte Waddell, who's University Professor and Director of the Children's Health Policy Center at Simon Fraser University, and her colleagues, Christine Schwartz and Jen Barican, also for Bev Gutray, who's the CEO of the Canadian Mental Health Association BC Division, and Rob Lampard, who's with the BC government. For Andrea Cipriani, who's joined us, I'm Michael Ostacher, the digital content editor for Evidence-Based Mental Health. You can watch our Hangout, which will be archived on YouTube, and you'll be able to watch it there. Let your friends and colleagues know that it's available. You can follow us at our Twitter handle, EB Mental Health, at EB Mental Health. And thank you so much for joining us. Take care.
Thank you.